Good evening, everyone. My name is Alfonso Aguaron, and I'll be moderating today's webinar. I would like to welcome you all to this webinar on spinal myeloma. As part of MP educational programs, this session has the aim on informing patients, relatives, and advocates about the spinal complications of myeloma bone disease and how it can be properly treated. The talk will be given by Mr. Sean Molloy, a consultant orthopedic surgeon at the Royal National Orthopaedic Hospital in the United Kingdom. On behalf of MPE, Mr. Molloy, I would like to thank you for your collaboration and for offering all of us the most up-to-date information on this topic. For your information, this webinar will be recorded and will soon be posted on the MP website, which is www.myelomapacientseurope.org. Before we start, I would like to make a small summary on the webinar dynamics. As you know, the webinar is scheduled for 7 to 8:30 Central European Time. So the presentation will last about 45 minutes, and then after the presentation I will open a session for you to ask any questions that you may have. We have received some questions by email, and I'll be reading them during that time, but you can also make yours. You have the possibility to make your questions in two different manners. First of all, if you have a microphone, which I strongly recommend you can press the raise hand button on your screen, and I'll unmute you so you can make your question when it's your turn. Then the other possibility is to do that in writing through the chat and questions window. I will get those questions and I'll read them to Mr. Molloy. This would be the version for those of you who have not a microphone or simply that you are a little bit shy. So you have these two options. So I wish you all a very interesting webinar, and I give you the floor, Mr. Molloy.
Thank you very much, Alfonso. It is a great pleasure to be able to speak to patients across Europe. As Alfonso said, I'm a consultant at the Royal National Orthopaedic Hospital, which is in London. We are very lucky that we have some very good hematologists in the London area, and they have worked very closely with us to try to give better care for you as myeloma patients. We see about 17 to 25 myeloma patients every Monday morning, and the clinic usually goes into the afternoon. The patients come and they get assessed with x-rays or scans if they are needed, and then they actually have some quality of life assessments done to see how they're getting on. So we're able to chart the progress of these patients on a week-to-week basis. What I'm going to try to talk to you today is a little bit about the changes in treatment of myeloma that actually affects the spine, because traditionally in the past it was very different. If we just deal with spinal tumors, so these are actually lesions of the spine that actually require treatment. They are relatively rare except for myeloma and, of course, what we call metastasis, which is somebody gets breast cancer and they may get a secondary or an extra lesion from the breast cancer occurring in the spine. It happens also with lung disease, maybe lung cancer, happens with kidney cancer, and a number of other types of cancer, but myeloma is one of the most common ones that goes to the spine. And in the diagram here we can see that the myeloma actually affects usually the front and the middle part of the spine. So here is a vertebral body, this is the back part of the vertebral body, and all of these are stacked upon each other and the spinal cord comes down through the center. So we see it here. This is the front part of the spine with a disc in between two vertebral bodies, which are the segments of the spine, and then we see the back parts of the spine connected by joints. In through these holes here passes the spinal cord. So the stability of the spine is something that we are really concerned about as orthopedic spinal surgeons, to make sure that you, all of you as patients, are safe. It is quite staggering how many patients with myeloma actually develop a spinal fracture. And in the literature, which is of course where we as doctors go and find out more about how to treat patients like yourself, it is said that up to 70%, and not all the papers have suggested this, but up to 70% of patients who have myeloma develop a spinal fracture. You can see that actually in this patient that I've shown the CT scan of, that actually it's created, because of the multiple fractures, quite a significant curvature of the spine, and in fact in this case the curvature is approximately 90 degrees. So these patients who present with a spinal fracture may not just complain of pain because of the fracture, they may have a significant curvature of their spine, and in rarer cases, and it may have happened to a couple of the people who attend today in the webinar, they get compression of the nerves or the spinal cord and require further treatment as a result of that. So the three major aspects that we have to deal with as a spinal consultant or as a hematologist treating you is the pain that you have, the curvature of your spine, or at least the prevention of this development of the curvature of the spine, and also we need to take the pressure off the nerves in the spinal cord. So if we deal with the pain first of all, the pain comes from the compression fractures of the spine. And these compression fractures occur because either the myeloma takes up and destroys part of your own bone, so it grows as a tumor and eats away your own bone, and this is really called infiltration, or we sometimes talk about these as being myelomatous deposits. Of course, if the myeloma destroys some of the integral part of the vertebral body, so the actual structure of the vertebral body, it decreases the strength and the stiffness of those vertebral bodies. In addition to that, when you are diagnosed with myeloma, you're often immobilized for a period of time whilst the hematologist works out whether your spine is stable or not with some scans, and also you feel pretty bad when you're having your chemotherapy and therefore may not be so active. So just being immobilized for a period of time will actually mean that your spine will become a little bit what we call porotic, so more porous. So that is actually where it's termed osteoporosis. But the osteoporosis that's actually caused by the myeloma is what we call a secondary osteoporosis, because it's not just a normal osteoporosis, it's actually caused as a result of the eating away of the bones, the steroids that you're given as part of the treatment of the myeloma, and also because of the immobilization that you have during periods of chemotherapy, or where actually somebody is working out whether your spine is stable. Historically, we have treated these compression fractures of the spine in myeloma patients with bed rest and painkillers. And the hematologists have told me that before the advent of the newer techniques that we have today, they saw a lot of patients that they were able to treat with their myeloma, but they had to give them large doses of morphine to be able to keep them out of pain. They also had to keep them in hospital for a very lengthy period of time so that they were actually safe when they went home and adequately out of pain. Often patients were given radiotherapy just to try to give some pain relief, but the radiotherapy itself wasn't necessarily causing increased strength of the vertebral bodies, it was just trying to eradicate some of the pain from the tumor itself. This is a confusing picture, but this is a patient's back looking at it from the side, and you can see that this patient's head is actually out of the picture because the deformity, or what we call the deformity, is the curvature of the spine is so great that actually this person is very tilted forward. This is the corresponding MRI scan, which is a special scan looking at partly the bones but mostly the nerves of the spine. And we know that patients who get 3 or more compression fractures of their spine have a significant effect on their quality of life. And this is comparable to a patient, for instance, who has had a stroke. And those patients with a stroke, of course, may have involvement of a leg and an arm so that they're weak and struggle to walk. But the same thing happens to the myeloma patients, is that they have a difficulty walking, not necessarily because of weakness of their legs or their arms, but actually because they're so bent forward. we know from the literature that if you get, and this is all this graph is trying to show, is that if you get one fracture of the spine, which is here, then you have an increased chance of getting a second one. If you get a second one, you have an increased chance of getting a third one, and so forth. So that there is what we call an exponential risk of getting more fractures once you have got one fracture. Our aim, therefore, is to try to prevent patients getting sequential fractures and having like a domino effect to increase the curvature of the spine. Because if actually they get multiple fractures, just like the lady I showed you a few minutes ago, then they get such a significant curvature of their spine that they actually have impaired walking ability because they're struggling to be able to see straight. They have poor balance. They have a disability and reduced quality of life. They often have reduced lung function and may get more chest infections. So what happens is patients are so tipped forward that they can't actually take deep breaths anymore. In addition to this, they also often complain of the fact that when they try to eat, they can only have very, very small volumes because they feel full at a very early stage. So they often don't eat very much and therefore can actually get run down quite easily. We've talked a little bit about the future fracture risk, and that is an exponential one. Traditionally in the past, we used to try to put metalwork into the spine to stabilize fractures. These may be confusing images to you, but just to keep it simple, this is looking at a patient from behind, and you can see that there's a screw put into the spine here, there's another screw here, and one here. And then there are two rods connecting the screws on both sides. And the reason that these were put in is that there was a fracture in the middle of the spine here, and the patient was in pain. So the screws are put in, but unfortunately, despite putting the screws in and the rods in a good position in this patient with this historical x-ray from a colleague of mine, actually, because myeloma is a, for want of a better phrase, a bone-eating tumor, it eats away parts of the bone and leaves holes within the vertebral bodies, which are the segments of the spine. The screw, in fact, in this case, has come out of the bony segment and gone into the next vertebra above. However, the patient has done very well, and they have actually grown bone, as indicated by the arrow, through the spine. But they are still left with, as shown on the right-hand side of your screen, quite a significant curvature of your spine, despite the metalwork being put in. So what we are trying to do is to find, in this day and age, better treatments to alleviate the pain of the spine and to stop doing such big operations like this and not having to put metalwork in your spine, which actually has a risk of failure because of the porosity of your bones. So the newer techniques that we actually have employed are essentially what we call vertebroplasty and balloon kyphoplasty. So just to explain to you a little bit about the differences between the two and actually what are they. Both of them involve inserting essentially acrylic cement into the fractured vertebra to stabilize the moving parts of that vertebra that is fractured and thereby relieve the pain associated with that micro movement. Vertebroplasty involves the insertion of metal tubes into the fractured vertebra. This image on the right-hand side is actually not one of mine. It was done and shown at another meeting. It shows multiple levels of the spine being done. In fact, I feel that only really 3 levels of the spine should be done at any one time, but I can go over why in a second. But the hollow tubes are put into the vertebral bodies, and under careful guidance, the cement is injected down these hollow tubes. It's a sticky cement, so it has high viscosity. The reason for that is we don't want the cement to leak out and affect the spinal cord, or in fact go into the blood vessels, which could potentially mean that it goes to the lungs and affects your breathing. But if one puts it in safely and uses high viscosity, so sticky cement, and puts the cement in at the appropriate time, you should be able to get a very good fill of the vertebral bodies, such as is shown on the right-hand side down here. So each of these have got a good load of cement put into the vertebral bodies, and the cement hasn't leaked out of the vertebral body. You can see with the white arrow up here that in this particular vertebra, some cement has actually leaked out of the vertebral body and has gone into the discs. This is actually quite safe in terms of a complication, but it just means that it may put a little bit more strain on the adjacent vertebral segment. The vertebroplasty aims to stabilize the fracture, as I detailed before, by decreasing the micro movement between the segments that have been fractured. The cement usually takes about 15 minutes to set, and after that point in time it has essentially provided immediate and sustained pain relief. The setup is really dependent on the unit that you get sent to or referred to for your treatment. You could have this done in an operating theatre, as is seen here, with two what we call C-arms, so two X-ray devices that will take 90-degree images of you to make sure that we know where your vertebra is at all times and where the metal tube is and where the cement is. It can also be done, however, in a CT scanning suite, so that you could be done in the X-ray department, where the technician or the doctor who's doing your procedure will actually put trocars into your spine very safely under sterile conditions and inject some cement into your spine. This is just a pictorial representation of how it's done. The green insignias here show that these are what's called the pedicle. And the pedicle is a bony channel between the front and the back part of the spine. So you are positioned on your front. Small little stab incisions are made, so with a knife, but very small, with some local anesthetic or some sedation or general anesthetic, really depending on the setup which the doctor uses to stabilize your spine. So hollow tubes are passed down through these pedicles, and then through the hollow tubes the acrylic sticky cement is put into your spine. And you can see in this case this was done by vertebroplasty, so just the hollow tubes. The cement has a very good fill, and there's no leakage of cement through this edge of the vertebra, this edge of the vertebra, or this one. And the spinal cord is back here. This is the back part of the vertebral body, so you want to ensure, and we take multiple images during the technique, to make sure that this cement does not leak back here towards the spinal cord. This is a very safe procedure when performed properly. Balloon kyphoplasty is the second type of technique that we use to put cement into the spine. You can see with the animation on the left-hand side that a metal tube is inserted into the vertebral body that is fractured, and down through that we put a balloon. The balloon is something like this, and the balloon is inflated to essentially try to create a cavity within the vertebral body for safe passage of the cement into the fracture to stabilize the vertebra. Many reports in the medical literature suggest that the balloon may also change the shape of the fractured vertebral body or the fractured segment and put it back to its original shape. That's not often the case, but it may actually stop sequential collapse of the vertebral body after the cement has been inserted. The kyphoplasty is thought, and is definitely reported in the literature, to have a decreased cement leakage. So when we put the acrylic cement into the vertebral body, it tends not to leak out of the vertebral body as much as possibly with vertebroplasty. However, If vertebroplasty and kyphoplasty are done by very skilled surgeons or radiologists or internal doctors, then actually both can be done in a very safe way. But then kyphoplasty may be the procedure of choice for certain types of fracture where the risk of cement leakage may be a little bit more. One of the rarer complications in the myeloma patient who presents to the hematologist or the spinal consultant is that they may get some nerve compression. The nerve compression may actually be just of one nerve supplying the legs or the arms, or it may actually be of the spinal cord. If it is of the spinal cord, then of course it could be threatening to the mobility of the patient, because if it presses on the spinal cord, then the messages don't get to the legs or the arms, depending on where the compression of the spinal cord occurs. However, myeloma, and this is very different from a lot of other types of tumors, is often treated very successfully with radiotherapy, chemotherapy, and steroids. So if we get some compression of the spinal cord in the myeloma patients, they often respond incredibly well to non-surgical treatments, so to radiotherapy, chemotherapy, and steroids. I'm going to show you a couple of case examples of this, just so that you can have an idea, because a couple of people who have dialed in may actually have had something like this themselves in the past. This gentleman was a 57-year-old man who presented to me in July 2010. His initial MRI scan, which I will show you in a second, showed that he had a myelomatous lesion, so a bit of soft tissue myeloma tumor sitting in the spinal canal. So it had come out of the vertebral body, which we've been talking about in the past, and it was pressing on the spinal cord. This gentleman, as a result, had no messages getting to his legs, and he had therefore leg weakness and also significant back pain because of the compression and because of the spinal fracture that he had in the vertebral segment. This is his MRI scan, and the MRI scan is excellent for showing the nerves. So if I orientate you, this is the back of the patient. This is the front of the patient, so effectively the patient is looking as if they're standing upright. The head is up here. This is the tailbone or the sacrum. This is the disc between the spine and the tailbone. It's called the L5S1 disc. This is the vertebral body. So is this, so is this, so is this. The discs, which are the shock absorbers in between, are here, 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 and so on. This vertebra down here, as you can see, is fractured, because if you look at the one above, there's a nice black line all the way across the top and a nice black line all the way across the bottom. But actually the black line here has a divot within it, both at the top and also at the bottom. So this vertebra is fractured. It may be giving this patient quite a lot of pain, and we could potentially do an injection of cement into this patient, so vertebroplasty or kyphoplasty, and stabilize this vertebra and therefore get rid of the pain. If, however, we look further up in the spine, which is here, not only is the vertebra here fractured, in fact it's very deranged in comparison to its normal shape. So its normal shape should be like this, but in fact its shape is like this. And the back wall of the vertebral body, which should look like this or this, has actually been broken out and invaded by the tumor. So the myeloma has actually come into the spinal canal and is pressing on this man's spinal cord. Here is the spinal cord coming down through the center of the spine. There is some white fluid in front and white fluid behind, which bathes the nerves of the spinal cord. So the white fluid has actually been blocked off here because there's some tumor in the canal. The white fluid is also blocked off at the back. So this gentleman had weakness of his legs because the messages were not getting through from the spinal cord here all the way down here towards the legs. We often do a CT scan as well because the MRI scan shows the nerves very well, but the CT scan in fact shows the bones better. You can therefore see the fracture much clearer. The vertebral bodies, and here are the discs. This is a fracture of the vertebral body down here, which could give pain, but the white is getting all the way down and the spinal cord is clear. Up here, however, there has been a fracture of the vertebral body, and some of the tumor has come out into the spinal canal and is pressing on the spinal cord. When that happens, the messages do not get down to the legs, and that's why this patient presented with leg weakness. We do a CT scan for a different reason. Essentially, the MRI scan shows the spinal cord very well, but as you can see, the CT scan does not show the MRI scan very well. Sorry, the CT scan does not show the spinal cord very well. It does, however, show the vertebral bodies and the fractures a lot better than the MRI scan shows them. If you look very clearly, very closely, you can see that there is a lump here in the spinal canal, and this is the soft tissue myeloma tumor which is pressing on the spinal cord, giving this patient weakness of both legs. The patient had radiotherapy because myeloma is what we call very radiosensitive, and this means that the radiotherapy melts away the tumor very, very well. We also put the patient into a plastic brace to give them some stability, and we gave them 2 cycles of chemotherapy. A lot of you will understand the cycles of chemotherapy because at the in-between stages of the cycles of chemotherapy, you're recovering, getting ready for the next cycle. We always repeat the MRI scan, and the images are really quite striking, not just in this patient but in multiple patients. And we have noticed here at Stanmore that patients with myeloma are very different than other patients who present with metastatic deposits of their spine due to breast cancer, kidney cancer, thyroid cancer, lung cancer, etc. So that myelomatous deposits in the spine often give quite a lot of compression of the spinal cord, but actually after they have been treated with chemotherapy and radiotherapy, you can see that the spinal cord now in the middle picture is completely clear. It has white signal in front of it showing that there is fluid in front of the spinal cord, and there's also fluid behind the spinal cord. If you look at the original images, you can see that actually there's no white getting through in front of the spinal cord and no white getting through at the back of the spinal cord. The image over here on the right hand side really is just a different type of image showing us as doctors any infiltration of the bones with myelomatous disease. So this patient now had a what we call a decompression, so an alleviation of compression of his spinal cord, and that meant that he now had normal power in both legs. He still unfortunately had quite significant back pain because of the fracture of the what we call the T10 vertebral body. So he had a thoracic vertebra, which is the middle of your back, fracture. He then went on to have an injection of cement, so we call it cement augmentation. It could have been vertebroplasty or kyphoplasty. In this case, he had a kyphoplasty to the T10 vertebral body to alleviate his pain. His spine was stable after the cement injection. He needed no further treatment, and his pain score, which we call a VAS score, which is just an inquisitive score for us as to what your pain is like, out of 10. So his pain score at 24 hours was 1 out of 10. So he was able to mobilize after this without any problems and needed no further surgical intervention. In the past, this gentleman would have had really quite extensive surgery to take away the tumor from the spinal cord and also to put metalwork in the spine like I showed you earlier, to try to stabilize the vertebral bodies. But in this case, all he required was an injection of cement. I'm going to show you a different example, but along similar lines. This gentleman actually had a lot of deposits of myeloma within his spine, but the red arrow will show you that once again he has a soft tissue tumor which has come out of the fractured vertebral body here and is pressing on the spinal cord. There is still a little bit of white signal behind the spinal cord, but this gentleman did actually present with difficulty walking, weakness of the legs, and also difficulty with sensation of both lower limbs. You can see once again, quite strikingly, from before the chemotherapy to after the chemotherapy, and this gentleman also had some radiotherapy, there is now no longer any compression of the spinal cord. And you can see that the initial MRI scan was done in the August, and the next MRI scan was done in the September. So just after a small amount of radiotherapy and a couple of cycles of chemotherapy, this gentleman has had complete alleviation of any spinal cord compression. The second thing we need to deal with, however, is his spine stable, and also is he in pain? So on the previous patient, I injected some cement into his spine to give him some stability and get rid of his pain, but in fact in this patient he had collapsed his vertebra above down onto the one below, and the fractured one in between had essentially disappeared. The bones were still connected at the back and also at the front, and he had no pain, so he required no treatment. You can, however, see on his CT scan that he had big holes in his bone, so every one of the bones in his neck should look like this, pointing out with my arrow. But actually this one here had collapsed completely, that's its shape, and up here all of this should look white. So all of this should look as if you have bone within it, but in fact it looks like fresh air. So the bone has actually eaten away. If we look at the rest of his spine, however, he has very large holes in his vertebral bodies because of the myeloma and the steroids, but what he has actually done is produced a lot of bone along the periphery of the spine that has given him some extra stability. And that is something that we have noticed here at Stanmore and has not been published in the literature, apart from one paper by myself as an expert opinion in the European Spine Journal. And if you look at this side, you can see in some patients they produce florid sheets of bone along the spine to create stability. We often put patients into a plastic brace here at Stanmore to give the patient some temporary stability whilst the bone grows around the spine and confers the patient stability in the longer term. This essentially is giving stability to all of the weakened vertebral bodies, and that's what our initial aim was many years ago, and even up to this date, by putting metalwork into the spine. So we at Stanmore have been able to decrease quite significantly the amount of patients that we have treated with metalwork fixation, and actually we just get rid of the pain from the fractured vertebral bodies by putting cement into the vertebral bodies, and then we often brace the patients so that they confer themselves stability by growing extra bone around the periphery of the fractured segments. This gentleman, just 2 months after his chemotherapy and radiotherapy, was able to move his head from side to side and also able to move his body without any restriction or pain. If we look at a separate case, something again very similar, you can see in the neck, here is a vertebral body, this is the spinal cord coming down through here, this is the back of the neck, here is the brain, and here is the chin over here. But you can see that there is a large myeloma lesion here which has eaten away part of the vertebral body here and a whole segment of the vertebral body here. This is a separate slice which shows that the myeloma is actually eating away the bone also at the periphery of the vertebral body. But that is only the MRI scan, and it shows us that the spinal cord is free, so the nerve structures are free. We can't say much, however, about the bony structures because it is only an MRI scan. So what we do there is a CT scan. So most people in this case, most surgeons in this case, would have looked at this and thought that the patient needed an operation. But actually, when we did the CT scan, we can see that the big hole in the vertebral body that has been eaten away by the myeloma is actually very stable because the patient has produced florid amounts of bone at the periphery and essentially done their own operation. So they have fused the spine along the anterior, the front aspect of the spine, and therefore do not need an operation. Again, at the periphery, they have produced bone all the way around the edges to again confer the patient stability. So this patient, contrary to the MRI scans which would have indicated in the past that this patient needed surgical intervention in the way of metalwork and rods fixation, actually doesn't need any intervention and in fact needs no cement injection because they have no pain. This is a very busy slide and I don't want you to look at it too closely, but we at Stanmore have developed an algorithm for patients who present up here with myeloma. We first of all divide the patients into ones that have no compression of their nerves, which will be on the left-hand side of your screen, and on the right-hand side of your screen, patients who present with compression of the nerves. If I take you down the much more common route, patients who have no compression of their nerves and therefore normal legs and normal arm function, they will come and if they have spinal pain, have an MRI scan of their spine, and we've got it down to about 10 minutes because it can be very uncomfortable for you to sit in a scanner and lie flat. We will also do a CT scan if we want to assess whether in fact your spine is stable. We then discuss your case with the hematologist and with the radiotherapy people, and we decide on your best course of treatment. We put you into a brace if we feel that that's going to help you. We give you pain medication to make you much more comfortable. If your pain is really quite significant, then we will think of doing an injection of cement into your spine with either vertebroplasty or kyphoplasty. In our case, our preferred technique is kyphoplasty, but we have reasons for that just because we have it available to us and we feel that there is a decreased risk of leakage of cement. The patients will continue on with their chemotherapy and we will get them in between cycles of chemotherapy for their cement injection. Importantly, patients will also start on what we call bisphosphonates, and bisphosphonates are the treatment that makes your spine a bit stronger in terms of the bone, so it stops the resorption of the bone due to the myeloma and maybe makes your spine stronger. If your pain is not so bad, then we may continue on with the chemotherapy, reassess your pain, and potentially at that point in time, if your pain is quite significant, then give you a cement augmentation, so an injection of cement into the spine to make you more stable. If, however, and I take you up to the top again, you come with compression of your nerve structures, so your spinal cord or the individual nerves going to your arms or your legs, then we will do an urgent MRI scan and we will assess you to see whether in fact you require urgent intervention, i.e. surgery to decompress your spinal canal, take out the soft tissue tumor and stabilize you with metalwork, i.e. screws and rods. However, in our institution we have been able to work very closely with our radiotherapy and hematology consultant colleagues to do an early CT scan, and if we see that it is just soft tissue in the canal, then we know that radiotherapy and chemotherapy are going to work very well, and we try to get rid of the spinal cord or the nerve compression with the chemotherapy and the radiotherapy. If we do that very effectively here, and if the neurological symptoms, so the weakness of the legs or the arms, whatever the patient presents with, improves completely, then we redo the MRI scan. If the patient is still in pain, as you saw with a couple of examples earlier on, we will then potentially give them an injection of cement into their spine to decrease their pain. If, of course, the patient does not get better with chemotherapy and radiotherapy, then urgent surgery may actually be needed. This should be, and this is a busy slide, but all of the decisions in this slide should be made by a team of doctors who are working and looking after the myeloma, the radiotherapy, and also any spinal surgery that you might need. So in conclusion, the take-home message is that myeloma is being treated so much better now than it was when, for instance, I was a medical student. Patients are doing incredibly well with their myeloma chemotherapy. Chemotherapy and radiotherapy is a very effective way of relieving any compression of the nerves, including the spinal cord. And often, therefore, spinal surgery is not needed to decompress or to take away the compression of the nerves, including the spinal cord. Cement injection, which is vertebroplasty or kyphoplasty, are excellent techniques, and they are minimally invasive techniques that can be done as a day case procedure to alleviate pain related to the fractures that occur with myeloma. They also give stability to the spine, and therefore the patient will not produce such a curvature of their spine if they have no treatment. Our experience also is that if we put people into a plastic brace and we give them cement for their painful fractures, then actually bone will form and grow between one fractured segment and another fractured segment or a non-fractured segment, and this will give them stability such that they will essentially do their own operation. So we would have in the past put in screws and rods into the spine to try to join one fractured vertebra to the next one to give the patient some stability. But in fact, the patients can do this themselves often, possibly because of the bisphosphonate treatment, but also because actually it is a normal fracture healing that occurs, and we're not too sure, but a lot more basic science research will be needed in this area to try to work out exactly what's going on. But patients with myeloma are different than patients with with other cancers. As a result of that, because the tumor is so chemosensitive and radiosensitive, and because bone forms and therefore essentially does the spinal stabilization operation by itself without surgical intervention, a bigger operation can now often be avoided in patients. But of course every case has to be taken on its merits and taken as a decision-making process between a group of doctors that is looking after your care. Thank you very much.
Well, thank you, Mr. Molloy, for this wonderful presentation. I think you stated many topics in a very clear way. So everything was very clear. But we are having some questions, and I'm sure there will be more questions. So I just, as I told you before, remember that you can press the little hand icon that you see on your screen to ask a question, or you can write it in the chat and questions window. So we have already received some questions, so I'm going to proceed. So first of all, John is asking us, should be considered the use of drugs such as zoledronic acid or denosumab to treat spinal complications in myeloma, just like if we were treating a solid tumor such as prostate or a breast cancer?
Okay, well, I think that's a very, very important question. So I was talking there about the bisphosphonates, which is essentially alendronic acid. But the chemotherapy regimes that you have also been alluding to, or the non-bisphosphonate treatments that John has alluded to, in fact work much better in myeloma than they do in prostate cancer, breast cancer, kidney cancer. So myeloma is probably the disease of choice for these medications, and these medications should be started as quickly as possible. Of course, alendronic acid and some of the bisphosphonates cannot be started on some myeloma patients immediately because sometimes they present with failure of their kidneys, and some of these drugs affect the kidneys, so we have to wait for a little period of time before we start them. But we think that, and there have been some reports, that the bortezomib and also the bisphosphonates such as the alendronic acid may actually create a better bone healing configuration for both the spine and also for the long bones, and therefore these patients may actually get better fracture healing than patients, for instance, with breast cancer or prostate cancer.
Good. Thanks for your answer. And Mike has sent us 3 questions, so if you want, I'm going one by one, okay?
Sure.
So the first question is, when you talk about tumors, is this synonymous with plasmacytomas? Plasmacytomas, sorry.
Okay. So a plasmacytoma is essentially a soft tissue mass of myeloma, essentially. But a plasmacytoma, if it is a solitary plasmacytoma, so just one plasmacytoma in the body, it may not go on to produce multiple myeloma. So it may be completely treatable with a high-dose radiotherapy regime, and the patient may not progress to multiple myeloma. However, if we see a patient with multiple plasmacytomas, then they essentially have multiple myeloma. And when we see a plasmacytoma, it is a big lump of tumor, and it's usually a soft tissue tumor, which can, of course, and I showed a few there in the images, come out of the vertebral body and press on the nerves, such as the spinal cord. So a plasmacytoma is just a mass of, yes, myelomatous tumor, and it's pressing often on neurological structures and requires treatment.
So the second question from Mike is it necessary to continue to take bisphosphonates when we are in remission, especially if the spine looks and damage on MRI or CT scans?
Okay, Alfonso, nobody has the answer to this at the moment, and I suspect that during the remission periods we probably don't need bisphosphonates. However, what I often see with patients is when they get diagnosed first, they become immobilized and they have chemotherapy and they have steroids. And the steroids is part of their chemotherapy. So their bone density decreases. And we often see them having 4 or 5 fractures over a short period of time. When those fractures heal, or if you put cement into the vertebral bodies, they are usually stronger than the original vertebral body and will not require any further treatment in the future. If you then get a relapse of the myeloma, of course, further weakening of the bones can occur because the myeloma eats away the bone once more. But in the in-between phases, we often don't need bisphosphonates. It may be, however, that there will be some guidelines that will state that bisphosphonates should be used to treat patients for up to 2 years following the diagnosis of myeloma. But nobody has really been able to decipher how long patients should be treated for. One of the ways that we are trying to do it at the moment is to have a look at what we call a DEXA scan. So a DEXA scan was traditionally used for osteoporotic patients to see how porous the bone was. So the architecture of the bone, was it strong enough to take the patient's load? So we have been trying to do a DEXA scan on some of the patients to be able to guide the hematologist as to how long these patients should be given bisphosphonates. Is that okay, Officer?
Yeah, that was quite clear, Doctor. So the final question from Mike is, the third question is, do you ever use bone scans to measure the density of the bones?
Okay, so part of that was the DEXA scan. So the DEXA scan is one that is used for osteoporosis, but in addition to that, you can do a scan called a qualitative CT scan. So you can do a CT scan and do a volumetric assessment of the architecture of the bone, giving you a slightly better indication of how strong that bone is and how much it will be able to resist the normal loads of a patient in day-to-day life. So I think the imaging will become better in time. We'll be guided by some better techniques, probably CT techniques, as to whether and how long we need bisphosphonate therapy. Okay, Alfonso?
That was quite clear also. So, well, these were the question from Mike, and we have received also a question from Paul, who raised his hand, but he also sent the question in the chat. So I'm going to unmute you, Paul, and if you are here, you can make your question, because my voice is sometimes very boring. So, Paul, can you hear us?
I can hear you, yeah, no problem at all.
Perfect.
Hi. Can you hear me?
Yeah, perfect.
Paul, hi, I can hear you. It's Sean here, yeah.
So I'm a GP and a relative of myeloma patient, and we're considering kind of vertebroplasty or kyphoplasty. And we're wondering, does vertebroplasty or kyphoplasty help to reduce kyphosis and increase vertebral height at all?
Okay, well, it's a slightly contentious issue, Paul, and so for the rest of the listeners who are not doctors, what Paul is talking about there is I showed an animation which is essentially a kyphoplasty animation just from one of the companies, where you put the metal tube, hollow tube, down into the vertebral body, and you put a balloon down through that hollow tube, and the animation was showing that the vertebral body that was fractured was then being restored to its normal shape and height. There are many reports in the literature that state that this partially occurs. My own reservation about that is that I haven't seen it myself, and I have over 380 myeloma patients under my care, and I haven't been able to either produce this or be able to show that it happens. I suspect the reason for this is that when we diagnose any patient, let's say just with a simple wrist fracture, if a patient has a wrist fracture, they don't have myeloma at all, and they're an elderly patient who's 70 years old, 80 years old, then actually if we try to manipulate that wrist fracture because it's in a bad position even at 10 days, there is some form of fracture healing, and it's very difficult to be able to get the shape of that wrist back to where you want to get it to. So I suspect that over a very, very short period of time in the spine, the same occurs, so that you get compression of the vertebral bodies, and it gets into a shape that actually we're not able to change. So I wouldn't, in my practice, tell patients that they're going to have a correction of any curvature of or deformity, which we call kyphosis in this case. They wouldn't get any correction of that kyphosis or deformity or curvature as a result of having either a vertebroplasty or a balloon kyphoplasty. I would say to them that I would be trying to relieve their pain associated with the fracture, and there may be a place in the future for injecting cement into a spine that has, or into a vertebral body that has not fractured but has a large myelomatous deposit within it, or poor bony architecture because it's been eaten away, so that we would put cement into the spine before actually that vertebral body fractures. I in fact wrote the first case that was done like that in the world literature in the Spine Journal magazine about 8 years ago on a gentleman who had kidney cancer, and he had a large deposit in one of the vertebral bodies and was just starting to get pain and a fracture. We put cement into his spine and we stopped it from collapsing, and he needed nothing further. But at the moment our imaging techniques are not good enough, and the predictability is not good enough to be able to say which vertebral bodies are going to fracture. So the short answer to you is that, in my opinion, neither vertebroplasty nor kyphoplasty will restore the height of a vertebral body, and neither will improve the curvature of the spine. The only caveat to that is that often patients hold themselves in a bent forward position because it's a slightly more comfortable position to be in when they've got fractures of the spine. So sometimes when you inject cement into the spine, they say that because the pain has been relieved, they can stand a bit more upright. Does that explain that, Paul?
Yes, thank you. That was it. But just a second part to that question.
Yes.
Would it improve respiratory function at all?
Okay. Well, no, it won't improve respiratory function really, because it won't improve the overall curvature of the posture. But we in our clinic are starting to do respiratory function tests on patients when they come to see us in the clinic to try to correlate the respiratory function with increased curvature and kyphosis. And therefore in the future we hope to be able to show, and we may be wrong, and the hypothesis would be that if we treat patients early and prevent them from going into kyphosis, significant kyphosis, then what we will be able to do as a result of that is stop them getting worsening lung function, possibly stop them getting repeated chest infections, and improving their quality of life longer term.
I do have a final question, if that's okay.
Of course, Paul.
Yeah, so it was just one other question. If a patient has multiple fractures on their spine, yet they're now becoming pain-free after chemotherapy, is it still likely in the future that they are more prone to things like spinal cord compression without a cement procedure?
No. That's a very, very important point, and a question well made, really. If the patients are going to present with spinal cord compression, they're going to present either at their initial point of contact with a doctor, so with a soft tissue plasmacytoma as part of their myeloma, or as just as a solitary plasmacytoma pressing on the spinal cord. If they then treat it with chemotherapy and radiotherapy, as long as they are responding well to the chemotherapy and radiotherapy, which is usually the case, and if they're not, they will go on to second and third line treatments, then the spinal cord compression or any soft tissue mass will be alleviated. We don't see patients who present with spinal cord compression some way down the line, especially when they're in remission, just because they had spinal fractures. In fact, the spinal fractures are actually stronger than they were before, and the lesions are usually well treated. The second time where we see patients with spinal cord compression is when they get a relapse, and often in that case they will present with a plasmacytoma as part of their myeloma, which is then pressing on the spinal cord, and it's probably more common actually that we see patients presenting with spinal cord compression during their relapse, because in fact the chemotherapy has stopped working for them, or they're kind of the chemotherapy that's trying to keep the myeloma at bay. So we do see some patients who then present at that stage with spinal cord compression. But the vertebroplasty and the kyphoplasty are merely a means of getting rid of pain. They may, of course, in a prophylactic sense, so injecting into vertebral bodies that may fracture in the future but haven't fractured yet, they may stop the curvature occurring. But there's no evidence at all, and I haven't seen a case that I've regretted not treating because the patients have got out of pain, because they don't go on to progressively get spinal cord compression.
Thank you.
Well, thank you so much. Yeah. Well, so thank you so much, Paul, for your question, and Doctor for your answer. Sorry about that. Next question comes from Ellen, who has raised her hand. So I'm going to unmute your microphone. Hi, Ellen. Can you hear us?
Yes, I can hear you fine. Yes.
Okay, so you can. Helen?
It's Ellen.
Ellen, hello, Ellen. Sorry, it's Sean.
Yeah, hello there. Hi. I work at Myeloma UK. I answer the free phone helpline, and I speak to lots of patients and families every day. And this is a question that I get asked quite regularly on the phone. So how important would you say exercise is in general, but perhaps specifically post-cement surgery?
Okay, Alan. Well, I think what's incredibly important, and because we often put patients into a plastic brace for a period of time, so of course we kind of augment or temporarily stabilize their spine partly by putting this plastic brace on. We don't want the patients to lose their muscle bulk and function. Of course, they're going to lose some of it, But we think it's imperative, and that's why I do my clinic with a consultant physiotherapist here from Stanmore. So the consultant physiotherapist sees every myeloma patient every time they come to clinic, and we think it's really imperative that patients be given exercises. We are close to putting an exercise program on our website so that patients could log in and be able to see the exercises that they could do safely, despite the fact that they've had spinal fractures and may or may not have had cement augmentation. We would usually say to patients that if they've got pain at that time in their spine, then they shouldn't be doing very much in the way of exercises. But once they've actually come out of that phase, whether they've had an injection of cement or not, if they're getting into the pain relieving phase of their presentation, then we would be very keen on them doing some very gentle exercises. And we should be able to help Myeloma UK and actually patients from around Europe by posting that on our website. We've just had so much to do recently that we haven't got around to that one thing. But the consultant physiotherapist in our case, her name is Suzanne, and she works with us and can be found on our website at Stanmore at the Royal National Orthopaedic Hospital, and patients can contact her to be able to get information about exercises that they could do. So you could, Ellen, if you want, direct them to us, and we'll gladly answer the questions from that point of view.
Thank you. Thank you. My next question was, should that exercise be overseen by a physiotherapist? But you've answered that. Thank you.
Yeah. Okay.
Oh, okay. So we'll go with the next question. It's from Stephen from Leeds, and he's asking us, I am 53 years old and I was diagnosed with multiple myeloma in March 2013, and I am on the myeloma 11 trial with maintenance drug Revlimid. What percentage of chances could I end up with a fracture of spinal problems? He says that I have one lesion on my spine. I suffer with occasional spasms in my spine, but I put this down to side effects of the Revlimid.
Alfonso, can you repeat the latter part of the question?
Yeah.
Just the end of the question.
Yeah, he says that he's suffering with occasional spasms in his spine,
yes,
but he puts this down to side effects of the Revlimid, of the lenalidomide.
Okay, well, I think it's impossible to tell Stephen. Unfortunately, Stephen, sorry, I can't help you completely with what we would term in medical circles a prognostic factor. So we can't tell you what the risks are of you getting a spinal fracture despite you being on maintenance dose therapy. Of course, if you've been diagnosed in March 2013, then you've gone through your initial very stormy stage of treatment with chemotherapy, possibly some radiotherapy at the time, and steroids, and you will actually be in really quite a stable condition at the moment. I think if you were to get any pain in your back, then it would be indicative of the fact that you either have a vertebral body that is at risk of fracture or one that has already fractured. And unfortunately, like I said earlier on, we are not able to, at the moment, with the current imaging, predict which vertebral bodies are most at risk of fracture. For breast cancer, for kidney cancer, for various types of cancers, we have developed a scoring system to be able to see how stable the spine is once the patient has actually fractured their spine, but it's probably not very good for myeloma. But what we haven't been able to do is to be able to predict which vertebral bodies are going to actually collapse, and therefore we can't really predict which ones we should inject with cement prior to them collapsing. I suppose if we did some sequential MRI scans, we could see lesions that were potentially increasing in size, and therefore they may have a greater risk of getting collapse of the vertebral body. But of course, if they are growing very, very slowly in size, then the natural fracture healing that we have seen here at Stanmore around these lesions may actually be enough to suffice to make sure that that vertebral body is actually stable. But in answer to your question, I can't really predict or couldn't say to you what your risks are of getting a fracture on your maintenance dose chemotherapy. We really, at the moment, are reactionary to pain that you get or symptoms that you get, we can't really predict what's going to happen to each individual patient. Okay, Alfonso.
Good. So next question comes from Simon. So I'm going to unmute you, Simon. Can you hear us? Hi, Simon. Well, it looks like, Simon, it looks like there are some kind of problem with your microphone because we are not able to hear you. So if you want, you can just type your question and I'll be glad to read it to the doctor. Okay, yeah, it's because Simon was sending the question for Steven, so he just he's just saying thank you for your answer, Mr. Molloy. So good. So I'm going with another question I have in the chat. It comes from Malina, and she said, my mother was diagnosed myeloma 2 years ago. The doctor said that the disease is progressing in their bones, so it can lead to compression of neural structures. He has suggested us to go for a balloon kyphoplasty. So what are the risks associated with this therapy? So I'd like to know whether there is any alternative.
Okay, well, in general, the indications, of course, for having injection of cement into your spine, whether it be vertebroplasty or kyphoplasty, would be pain or risk of fracture. And it sounds in this patient's case that there is a risk of fracture. We wouldn't normally put cement into the spine, like I said to Paul, the GP, earlier on, to prevent any spinal cord compression because there's no link with that. I don't see patients who develop soft tissue compression of their spinal canal as a result of tumor. The only thing that one could be a bit concerned about is that if there is destruction of the bone to such an extent that maybe that bone itself could fracture and the bone could press on the spinal cord. We very rarely see that in myeloma, but I've probably seen it 4 times in the last 5 to 6 years. So it's not very common. But if the surgeon has indicated that the patient requires a balloon kyphoplasty, then it's really because they feel that the spine needs to be stabilized at that level. I think the procedure is incredibly safe. Over the last 10 years, I've probably done something in the region of 850 injection of cement procedures, whether it be vertebroplasty or kyphoplasty, and the risks of the procedure, if done safely and correctly by an experienced person, are incredibly small. In fact, we haven't had any nerve compressions or spinal cord compressions, because that is the risk of cement coming out of the spine into the vertebral body. The only case I had with a problem with cement leakage was not actually in a myeloma patient, but in a patient with osteoporosis, where they had a sacral fracture, and injecting cement into the sacrum is not as safe a procedure as it is injecting it into the spine. And a little bit of cement leaked out of the front part of the sacrum and caused some excuse me, some thermal damage, so some heat damage to one of the nerves going down the leg. But the patient recovered after that. But in myeloma, I've never seen any compression of any nerve or injury to any nerve with a balloon kyphoplasty under my care. I think it's very safe.
Good. I think that was a very nice question. So I hope, Alina, now it's more clear to you. It's clearer to you all about this procedure. So we still have some questions. There are 15 minutes left, but I think we can do it. So next question comes from Sergio, and he said, my father-in-law has relapsed and he's going through back pain. He's using an external orthosis for the last 3 weeks, but the pain remains awful. I'd like to know if it would be advisable to look for alternatives, like a surgical procedure. Also, I'd like to ask you what kind of effective pain relief treatments would be recommendable.
Okay, well that is a great case. So we often put, well, we pretty much put all of our patients initially into a plastic brace just to temporarily stabilize them whilst they're having all their scans and so forth. If they are still in pain whilst in the brace and requiring quite a lot of painkillers, then we would proceed to doing an injection of cement under the guise of a balloon kyphoplasty. So we would say that if the patient, in fact in our guidelines we suggested that a pain score of 7 or more, but really you have to look at the patient themselves and see how much in the way of painkillers they're taking, because some patients are taking up to 80 milligrams of morphine per day, and then they will report their pain score as being only maybe 6, but actually if you were to take them off the painkillers it might be 10 out of 10. So it seems like a very good indication to get an MRI scan in his case, see which vertebral body is fractured, and then inject cement into that spine, usually by a balloon kyphoplasty if it's done in our institution. But if it's done in other institutions, vertebroplasty may be a very safe and effective modality to be able to be used for that individual fracture.
Great. Great. So next question comes from Ananda. So Ananda, I'm going to open your microphone so you can ask the doctor. Ananda, can you hear us?
Yes, I can. Good afternoon, Mr. Molloy. This is Ananda Plata from MPE. On behalf of MPE, hi, how are you? I'd like to thank you very much on behalf of the whole team for this very, very comprehensive and clear presentation. I finally understood something about spinal myeloma, and I was very impressed about the algorithm you showed. And wanted to ask you, I mean, thinking of all the patients we represent across Europe, I'd like to ask you whether you're aware of this being treated, or spinal myeloma being treated in a similar way across countries.
No, Ananda. I mean, I think I've been very lucky because essentially the patients have taught me a lot about their disease process. All I have done is just to watch them, and I've observed their recovery or their treatment, and they have taught me a huge amount. The algorithm that I showed there was actually an old algorithm, and the reason I showed you the old algorithm was it wasn't fair to show you the new one just yet, because just today we sent off the revised algorithm for publication to the British Journal of Hematology. We have collaborated here at Stanmore with 6 or 7 of the largest spinal units in the country, and also with the respective hematologists who work at those institutions, to be able to set down guidelines for patients so that they can be treated effectively if they have spinal fractures related to the myeloma. So the algorithm, I couldn't show you the absolute algorithm pre-publication, but we're very happy to share that with any clinicians who want it. But any patients who want to see it, or for the myeloma institutions, whether it be in Europe or in Britain, hopefully the British Journal of Hematology will publish the algorithms so that spinal surgeons or radiologists can stick to or be helped by the algorithm to be able to treat the patients more effectively.
Thanks. And if I may just ask you, I mean, I'm not sure whether you will know this, but I mean, this vertebroplasty and balloon kyphoplasty seems to be an amazing way of for patients to get rid of their pain due to spinal complications. I mean, thinking of the countries where maybe that isn't reimbursed, do you know if this is super, super expensive, or if it's
Ananda?
Yes, I am here.
Yeah, I mean, look, traditionally when it came out at the very beginning, it was very expensive. In time, as this procedure is done more and more, there will be a drive to push down the price of this procedure. But it's an incredibly effective means of relieving pain. In fact, I think it's the most effective treatment for any spinal condition. So if we think about doing spinal deformity operations, spinal fusion operations, disc surgery for patients, balloon kyphoplasty or vertebroplasty, injection of cement into the spine is the most extraordinary procedure for patients. They go into hospital with possibly a pain of 8 or 10 out of 10. They come in on very large doses of morphine, and they have a surgical procedure which in my hands now takes about 10 to 15 minutes with a very low risk. The cement sets in 15 minutes roughly, and they go back to the ward and can get up the same day and walk around essentially pain-free. In fact, I've had some patients who have stayed in hospital for an extended period of time to wean them off, so to get them off their morphine drugs because their pain is gone, and now they're addicted to morphine because they've had it for so long. So it is the most incredible treatment, but it's imperative that we try to see if we can get the companies to make it available to all patients throughout the world, because it's such an effective treatment. And it's a bit sad to see that if you go to a casualty department in any country and you've even broken a finger, that they will put a splint on your finger, but if you have a fracture of your spine, you'll get no treatment.
Yeah, I was mainly thinking of our Eastern European countries where we have members and so on. No, it's very interesting. Thanks a lot.
Yeah, for sure.
Well, thank you, Ananda, for your question, and Mr. Molloy for your answer. We still have some questions. So next one is Mike, who wants to make again some questions. So Mike, I'm going to open again your microphone. Hi, Mike. Can you hear us? Hi, Mike.
Hello?
Hello, yeah. You can proceed with your question to the doctor.
Mike, hi, it's Sean here.
Hi. Yeah, thanks very much. I was just wondering, do you ever see any bony changes when the blood and protein levels are quite within normal limits?
Okay, so I think
ongoing bony changes.
Okay, very rarely actually, Mike. I think that there's an extended answer to your question, and actually it's going to be something that's going to take up most of my next 4 to 5 years in terms of research.
Okay.
And that is that essentially when patients present initially, of course their blood parameters and their urine parameters and so forth will show that the myeloma is very active. When the myeloma is under control, then the bony changes are stabilized. There have been many occasions where I have contacted the hematologist and said, look, something's going wrong here. I've seen this patient. The MRI scan shows that they've actually had a progression of certain lesions in their spine. I don't think that the chemotherapy regime that you have them on is working. And it will usually go in concert with changes that have just happened in their bloods. So I don't know which one goes first. Probably a change in the blood parameters. Probably it would be more sensitive if you pick it up first. But I do see some patients who haven't seen the hematologist maybe for some time, and I've seen them for their spine because they come back because they've got some new pain because they've got a new fracture, and they haven't seen the hematologist, and I will contact the hematologist and say, look, I think this person has some progression of the disease or some relapse of the disease, or the chemotherapy regime that they're on is not working for them. The second part and the extension to your question is that in the presentation there, I presented that myeloma patients, despite having fractures of the spine, often grow extra bone around the periphery, which is something that hasn't actually been reported ever before. And I've probably seen it now in over 70 patients, and we're going to present essentially our work here, and I'm going to make it as part of an MD thesis so that that question doesn't have to be learnt again in the future. And what I see is that actually good control of the myeloma from a blood and biochemical point of view has to occur for that fracture healing to happen around the periphery of these fractures. So if the myeloma is not well controlled with the current regime of chemotherapy, then the patients do not get fracture healing. So it's imperative that the patients get an appropriate chemotherapy regime for them so that actually fracture healing can occur and stabilization of the fractures can happen. Does that make sense?
Yep, that's excellent. Thank you very much.
Thank you, Mike. Now the next question comes from Paul. So Paul, again, I'm going to unmute your microphone. Hi, Paul.
Hi there. Hi.
Okay.
So further question really. We've been given some conflicting advice about the best imaging technique to evaluate the need for the cement procedure. We thought it was MRI, but then someone said it might be an isotope bone scan. Can you let us know what your advice would be in this situation?
Okay, so the very large myeloma, sorry, Paul, the very large myeloma group in I think it's Heidelberg in Germany, they do very low dose CT scanning to try to pick up clefts within the vertebral bodies that may be new or that actually are vertebral bodies that haven't healed. So that's one modality. We don't use that. We use the CT scans for stability of the spine to have a look and see whether in fact a patient is going to be safe and whether they can come out of the brace or not. So we don't use that as the first modality, but I can see that as it's a very apt modality to use. MRI scanning is very good for an osteoporotic fracture because it will show increased swelling or edema on what we would call the stir images. So it's a type of image, and you're probably aware of it yourself, being a GP. But it's a type of image on the MRI scan that shows us essentially swelling inside the vertebral body. So on the stir image, it will be bright, and on the what we call the T1 weighted images, which I actually showed on one of my slides earlier on, it will be dark. And so both of those indicate swelling and edema, and therefore would be an indication for injection of cement into the vertebral body. I wrote that up in the British Journal, the Annals of Surgery in Britain some years ago. But actually, I can understand what you're saying about the isotope scan. It's interesting that somebody might be even thinking about using that, because I think we were probably the first people to start doing that, and we have about 280 isotope scans on various different patients for different pathologies at Stanmore. And it's interesting that a bone scan is often said to be what we say cold in myeloma. So that if you do a bone scan looking for, let's say, metastatic disease, so spread from a cancer, if it is breast cancer, you will pick it up possibly on a bone scan, but if it's myeloma, you may not, so they'll be cold. But we're starting to use, I suppose, a change scan, so it's an altered scan. It's a CT scan and bone scan together, called a SPECT CT scan. And we're getting more experience with that, and we are going to publish some data on using a SPECT CT scan. So if the MRI scan is not very useful in a patient's case, and sometimes it's not useful in a myeloma case because the vertebral body is so overtaken by the myelomatous disease that the vertebral body cannot actually produce an edematous, so a swelling response, then actually a SPECT CT scan can be very useful. SPECT CT scans can be very useful. I have at least 8 to 10 cases where the MRI scan has not shown the fracture, and I've done a SPECT CT scan and it has shown where the fracture is. Patients may have 8 or 9 vertebrae that have changed shape, so they've fractured at some stage, but you're not too sure which one of those is actually the painful one. And I've got about 8 to 10 cases where the MRI scan wasn't showing us which one of these was fractured, and the SPECT CT scan did. But if it's just a normal bone scan, then I would say that's probably not the best modality to do, although you can potentially pick up the fracture and the stress from that, but you won't necessarily pick it up of just a myelomatous lesion. So there's two different things. The first one is myelomatous lesions are not picked up by bone scanning, but the stress response related to a fracture may actually be picked up by bone scanning, and SPECT CT scanning is probably going to be our modality of choice in the future to pick up those slightly occult fractures that occur that we can't pick up on MRI scanning.
Right, thank you.
Thank you, Paul. We have just 2 more questions. I think we are almost on time, but I think we can make it. So next question comes from Krista. So Krista, I'm going to open your microphone. Hi, Krista, can you hear us?
Yeah. Hi,
Good.
hi, Alfonso. Yes, I can hear you.
Hi, Krista.
I've been informed of a new treatment called radiokyphoballoon kyphoplasty. It's like this. What do you think about it? Can you see any advantages by this new method?
Okay, so Chris, I think what you're talking about is to essentially try to ablate the tumor. What we call ablate the tumor means to burn the tumor. Essentially, you're putting a material or a wand into the actual tumor itself. It's used for liver cancer metastases. It's been used for other spinal tumors in the spine as well, and it essentially tries to burn the tumor and create a safer environment before one inflates a balloon and puts a balloon and cement in. A lot of people have done this in the past and have gone away from it again. One of the reasons for doing it in more solid tumors such as breast cancer and so forth is that it essentially is trying to decrease the size of the soft tissue tumor mass. So if there is tumor in the spinal canal, then we wouldn't go on to do an injection of cement procedure until the spinal canal is completely clear. So the radiotherapy and the chemotherapy in myeloma will essentially eradicate that tumor themselves, and then the cement is really just to stabilize the fracture fragments to decrease the pain. So the coablation techniques, the ablation techniques, all these techniques that I think you're alluding to have been around for some time and have been used for a lot of tumors, and they're probably not as useful in myeloma because myeloma is so radiosensitive and so chemosensitive. So it's often not needed in myeloma setting.
Thank you.
Pleasure.
Hi? No.
Alfonso?
Yeah, can you hear me now, Mr. Molloy?
Yes, I can hear you.
Okay, sorry about that. I think my computer has some problems. I was telling that there is one more question. We are on time. I don't know if we have time for one more question, Mr. Molloy.
We can try, no problems.
Okay, perfect then. So the last question comes from Andrew. So Andrew, I'm going to open the microphone now. Hi, Andrew.
Hi there. Can you hear me?
Yeah,
Andrew,
perfect.
I can hear you.
Good. Right. I'm under yourself at the Orthopaedic Hospital. I'm just about to go in for my stem cell transplant next Monday.
Yes.
And what I'm wondering about is I have two thoracic fractures at T8 and T9, which are actually causing me quite a bit of pain. Now, obviously, I'm going to be out of action for quite a few months. Will this have any effect on whether I can actually have any intervention, i.e. cement injections, that type of thing, when I come out of the other side of the stem cell transplant? I understand that there is some concern that the bones will start to heal up by that time, and you may not be able to actually perform that procedure. That is basically my question.
Andrew, that's a great question, and I'm delighted that you brought it up. Essentially, all patients, we take all patients on the merits of what their pain is like at that particular time. So if your pain is significant at the moment, then we should try to get your balloon kyphoplasty done before you go for stem cell transplantation. And the reason I say that is that when you have stem cell transplantation, you will essentially be rendered immunocompromised, so that your risk of getting an infection, if we were to do a balloon kyphoplasty at that stage and during that treatment, would be too high, and therefore we wouldn't do it during that period. So we like to try to do the balloon kyphoplasty in between cycles of your chemotherapy. So the stem cell transplantation, of course, is a radical form of getting rid of all your cells and immunocompromising you, so we wouldn't want to put you at risk of doing a cement augmentation or a kyphoplasty at that time. So ideally it would be better for you, and the hematologists normally know that, and if you come and see us, then we would normally do the balloon kyphoplasty before you go in and have your stem cell transplantation.
Yes. The problem is I'm actually due this coming Monday to go in for my transplant. So obviously I would have to wait some time. When I say I have pain, it is painful, but I can get around. It's not a problem. Obviously, I would prefer to get the cancer knocked on the head first, and then go for the treatment. But is there? My main question is there any problem in waiting that length of time before we actually do the injection of stuff into the spine?
There's no problem with that, Andrew, because those fractures will probably in time heal themselves if you can put up with your pain for long enough. That's essentially the equation. If your pain is significant, of course, we should be doing it now. If your pain is manageable, as you're saying at the moment, then what we could do is we could put you into a brace for a short period of time whilst you're painful during your stem cell transplantation phase, so that to make sure that you don't get a progressive deformity. You sound like a relatively young, strong man, so actually you're at less risk than if you were possibly a female and possibly osteoporotic anyway because of the age. So you have a decreased chance of getting a significant deformity. But if you are worried about that because you have significant pain or you get progressive pain, then we would advise you to be braced for a period of time until those fractures heal, and they should heal themselves in time. But we would brace you until those fractures have healed so that actually we didn't leave you with any lasting deformity as a result of those.
Right. That's quite interesting. We'll have to see how things go anyway.
Yeah.
Well, thanks a lot, Sean.
No problems at all.
Well, thank you so much, Andrew. And it seems that we run out of time. So before we end, and once again, Mr. Molloy, I would really like to thank you on behalf of MPE for giving us your valuable time. I think it's been
no problems.
I think it's been a very fruitful evening, knowing more about the spinal complications of myeloma bone disease. So thank you so much. And I would like also to thank you, all of you, for joining us during this evening. Just remember that the whole content of this webinar has been recorded and will soon be posted on the MPE website. So without further ado, I encourage you to stay connected with us, to follow our upcoming activities through our website and social networks in Facebook and Twitter. And we strongly recommend you to check our member section in our website so you can connect with your local myeloma organization just in case you haven't done it yet. So we're looking forward to see you in our next webinar. And once again, thank you so much for trusting Myeloma Patients Europe. Good evening, everyone.
Thank you, Alfonso.
Thanks.